My name's Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, Massachusetts, and I'm really happy to be here today to talk to you about some interesting topics. Following completion of therapy, as we know, patients with gastric and esophageal cancers remain at high risk for recurrence. Patients with node positive or primary tumor positive disease at the end of therapy after surgery, some estimates the progression-free survival in the 1 year range, potentially less. On this context, it's important to think about how can we follow these patients to try to optimize early detection of recurrence to potentially inform management and consider even salvage for cure in some patients. So for the average patient who completes, whether it be perioperative or total neoadjuvant or adjuvant therapy, our standard surveillance is consistent with what the NCCN has recommended in terms of total duration of surveillance approaching 5 years, as well as methods. We're trying to continue to advance this field and consider the role for minimal residual disease testing, although admittedly this remains investigational in the field of gastric and esophageal cancers. Our standard approach has been patients who complete definitive therapy and undergo surgery, so trimodality therapy or perioperative therapy, has been scanned roughly every 3 to 4 months using a CT, chest, abdomen, and pelvis, every 3 to 4 months for the first year, and then tailor a little bit in the second to third and fourth years, often spacing this out into the 4 to 6 month range. And then in years 3 to 5, consider annual surveillance for people who are doing well. The role for surveillance endoscopy is unclear. Patients who have recurrent symptoms, certainly symptom-prompted endoscopy is warranted, but the role for scheduled surveillance endoscopy in the absence of symptoms remains unclear. So the take home is that we have followed patients after definitive curative intent therapy with roughly CT scans every 3 to 4 months for 1 to 2 years, followed by every 6 to 12 months, all the way out to 5 years. And we incorporate endoscopy on a symptom-based approach. In addition, we follow minimal residual disease based on ctDNA testing. However, this remains investigational and is done primarily for research, not to inform clinical practice as of yet.